Hey, how's it going? This is Dr. Babbar. Good evening to everyone who's tuned in today. So thanks so much for being here. So we're going to talk about erectile dysfunction today. And one of the great things about, this live format is I really would love any questions that y'all have. If you want to just type it in the chat box, it's fully anonymous and no one else can see your questions. And then at the end of the webinar, I'm going to try to just go through those and answer whatever questions you may have, and so we'll definitely do that. So, perfect. Let's get going. So my name's Paurush Babbar. I'm one of the urologists here at the Urology Group. I grew up in Melbourne, Australia, and I moved to the States for high school, and then went to in Atlanta. Was where I did high school, and then I went to med school and undergrad at Wake Forest in North Carolina. And then one of the most fortuitous moments of my life, getting selected to do my residency at the Cleveland Clinic, which I think is the preeminent urologic institution in the United States. And there I got to experience a wide variety of urology, stones, female urology, kidney transplants, cancer, whatever it may be. But it was always men's health and reconstructive urology, which was my passion. And I found that early on, luckily, and just really tailored my experience at the Cleveland Clinic for that. And I was lucky enough after my 6 years of residency to be able to stay on for a fellowship year in male reconstruction and penile implant surgery, prosthetics, and men's health. So these are some of my specialties that I specialize in. And I see patients out of the Norwood and Eastgate office. So yeah. Perfect. So to dive into today's topic, so erectile dysfunction, what is it, who has it, what causes it? So simply put, erectile dysfunction is an inability to achieve or maintain an erection firm enough for sexual intercourse. As can be seen by the definition, it's very subjective, right? So for what one man is a good erection, for another man may not be sufficient. And so we really hone in on that and try to understand: is it an issue with initiating an erection? Is it maintaining? Is it an issue with orgasm, ejaculation? Because all these little nuances matter. It's not, you can't just put it all as one. So and all an erection is, really simply put, is more blood flow into the penis than the blood flows out. So as we get older sometimes, or if you have comorbid conditions like diabetes, you've had prostate cancer treatment, the blood flow to the penis can be impaired, and then that's erectile dysfunction. So there's multiple causes and multiple subpopulations who have it. So essentially, it's very prevalent. I want to always stress to patients that no one chooses to have erectile dysfunction, but you certainly can choose to get treatment for it. And so even things like tuning in for tonight's webinar proves that you're taking ownership of your health, and that is the first step and most important step, I think, in all of this. So 1 in 5 men over the age of 20 will experience ED in their lifetime. 40% of men over the age of 40, which be surprise a lot of guys. I see quite a few men in their 40s, and they're like, I didn't expect this, but it is pretty common. And then once men are over the age of 70, nearly 70% of men will have some erectile dysfunction. So all in all, 30 million American men, we think, are affected, and so it is a vastly undertreated condition. I think it's multifactorial why that is. I think part of it is that us as urologists, we haven't tried to get the word out that, hey, we have lots of good options. We can help. Like people go to some of these men's health clinics. You have to ask, are they run by fellowship trained urologists who've spent their life trying to do these conditions? That's one thing. So you want to go to someone who specializes in it. And I think patients sometimes get a little embarrassed, and there's no reason to be embarrassed. Look how common this is. This is kind of part of just getting older, and if you can take control of this and address it head on and not bury your head in the sand, I think that is absolutely critical. So this slide is more technical, but it talks about how an erection works. It's an interplay between arteries, veins, nerves, and ultimately, for me, it's simply that it's about blood flow in, blood flow out. And so this 1, 2, 3, 4, 5, I think is more for me to know on my board exam, but I don't think it really clinically matters. But you should think about it's the arteries, the veins, the nerves. And so certain conditions will affect just the arteries, like, if you have atherosclerotic plaques, high cholesterol, things like that, then you can have decreased blood flow to the penis. Diabetes will affect all three: the arteries, veins, and the nerves. The increased blood sugar will damage the endothelium, or the inner lining of the vessels, and will also cause some nerve problems. So all of these factors, if you have a nerve damage from a spinal cord injury, then you can have erectile dysfunction. So it's pretty complex, but in the end you can distill it down to just these components. So common causes of erectile dysfunction. The things that I think about when I see patients are diabetes, previous pelvic surgery, prostate removal, colorectal malignancies, anything in the pelvis where you've had surgery and there could be some nerve damage. Low testosterone, I generally do like to talk about that in most patients, and that can be a cause of erectile dysfunction. Radiation therapy, absolutely critical. If you've had radiation in the pelvis, that can absolutely affect the quality, integrity of erections. And then medications is definitely important. Things like, if you have advanced prostate cancer and you're on hormonal therapy, if you take some psychiatric drugs, schizophrenic drugs, those absolutely can affect your erection quality. And then one thing that is so critical that sometimes patients maybe don't understand the importance of is your overall psyche, depression, anxiety. If you're going through a tough time in life, if you're stressed, it's hard to have good erections, so that is totally normal, and there are things that we can help with that too. So we like to definitely have a thorough evaluation of these things and then find the solution tailored to you. So things that can help, I mean, this is all my internal medicine and family medicine colleagues will agree. I mean, diet is absolutely important. Exercising, maintaining a good BMI, losing weight, limiting alcohol, not smoking. I mean, smoking is terrible for your health, and it does not help your erection. So even if one man on today's can quit smoking because it's messing up their erections, then that's the today's webinar was a success. I mean, smoking is the worst thing you can do, and so that absolutely will affect your erections. Reducing stress, sleeping well, all these things are absolutely critical. So few things, yes, certainly heart disease, diabetes, these can affect erections, but three things I want to kind of deep dive into a little bit today, because these are more urologic conditions that we treat that also go hand in hand with erectile dysfunction. So low testosterone. So 40% of men over the age of 45 may have a low testosterone level, and this percentage certainly can rise as men get older. And low testosterone can cause low libido or sex drive. It can cause erectile dysfunction, weight gain, loss of muscle mass, concentration deficits, fatigue. I mean, it really affects the whole man. So it's very important that we check a testosterone level many times when we're evaluating a patient for erectile dysfunction. Next is Peyronie's disease. So 9 to 12% of men over the age of 50 will have Peyronie's disease, which is an adult onset acquired penile curvature. So, I don't want people to start freaking out. Oh, a lot of guys will have a little bit of a tilt or a curve to their penis. No penis is absolutely straight, but I'm talking about like a very significant curve where that impairs penetration during sex. And these can, that we think they happen actually a lot of times because you have erectile dysfunction, you get some micro trauma to the penis, there's some scar tissue deposition, and it starts hooking the penis. So that's something that we can absolutely help with and treat too. And then prostate cancer, most common cancer in men outside of skin cancer. 1 in 9 men will have it in their lifetime. And some of it's not the actual prostate cancer, but some of the treatments that the oncologists need to do to kind of save your life can sometimes have effects. So we think the radiation, even the surgery or hormonal therapy, all of these have in various ways can affect erection. So we'll go into that too. So low testosterone, occurs when a man's body does not produce as much testosterone as normal. It increases with age. And here are some of the common signs and symptoms like I allude to: fatigue, loss of energy, decreased muscle mass, increased body fat, hot flashes, reduced sex drive, or low libido, we call that. And then it also has a big effect on your mental and emotional well-being. Depression, anxiety go hand in hand, poor concentration, memory deficits, things of that nature. So if you're feeling these, sometimes your primary care can check the testosterone, or if you come to us and you talk about it, we will check it. And a few questions we want to know is, are you still interested in having kids? Because that will tell us how we want to replete the testosterone. And then we kind of understand your goals and try to, if it's low, then we start repletion of that, and that can sometimes help with some of the symptoms listed there. So it's treatments, this is a little more complex and a little different from today's discussion, but we have gels, solutions, there's oral medications, nasal sprays, nasal gels, patches, pellets, injections. So a lot of treatment options, and we at Urology Group, we have a system, a protocol that we have in place where we measure the labs, and we really maintain a very tight level. So we're not like a men's health clinic where we boost your testosterone level to the moon and to a bodybuilder level, because that's when when you hear testosterone has a bad rap. I think it's when you run your testosterone super duper high. Yeah, you're gonna feel great, you're gonna make muscle like no one else, get that beach bod you've always wanted, but then you could have a heart attack or stroke and die early too, right? So it's key is you want to maintain a very tight level, and that's what we achieve. We want to do it safely is the key. Safety is the number one for us. And so we measure your labs routinely, and we get the prescription from our pharmacy and send it to you. And we have two PAs, Melissa Helton and Mary Garrett, who are absolutely incredible, and they will kind of make sure that you're getting the right dose, the right formulation, and that it's done safely, like I said, and you're having good benefits. So that's a great service that our pharmacy and our team offers. So Peyronie's disease, or that adult onset acquired penile curvature that I mentioned, 9 to 12% of men over the age of 50 will experience this. We think it happens when you have erectile dysfunction, and it's kind of in its early stages, right? So you're having sex, and let's say when you were 20 years old, your erection is a 10 out of 10, and now at 55, it's a 8.5 out of 10. You're having sex, and there's just a bit of hinging, and imperceptible to the patient and their partner, and there can be some micro tears in the inner lining of the penis called the tunica, and this can, in these 9 to 13% of men, there can be some deposition of scar tissue. And that scar tissue, it's not as elastic as regular tissue, and it starts to hook the penis. And so what happens is that you'll have a curve, and then patients will have a loss of length. So that's, pretty alarming. And then in its worst cases, you can't penetrate anymore. So it's vastly undertreated, because a lot of guys don't even know what's going on. They're just in a fog or a daze. They don't understand. And it can be loss of length, it can be pain with erections in the active phase in the first few months, and then some ED as well. So we do have certainly some treatment options. It just depends on when it started, if there's pain with it, the amount of curvature, if you have how bad the erectile dysfunction is with it. So there's some traction devices that we recommend in some patients. Xiaflex is a medication that breaks down scar tissue, and we inject it directly into that plaque. It's a course of about 8 injections over a few months, and on average, it can decrease the curve, about 17 to 20 degrees or so. And then there's surgery such as penile plication, which is where we take pinches out of like in this case, it would be the bottom side of the penis to match it to the top side. There's other surgeries, incision, excision, and grafting. So in more severe curves, we would cut out the plaque and put a graft on the penis. And then lastly, in patients who have both erectile dysfunction and Peyronie's disease, the gold standard would certainly be a penile implant, because we will address both of these issues and straighten the penis and also help with erection. So, if this is something that you're dealing with, and it's something that we would be happy to help with. And next is prostate cancer treatment. So erectile dysfunction can occur after almost any of these treatment options, as discussed: radiation, surgery, hormones, and then the last one's a little more rare, but certainly still done: cryotherapy, proton beam, or HIFU. And that's the reason we think this happens is the nerves that predicate erections run on the side or lateral aspect and posterior aspect of the prostate, and so any treatment can sometimes affect the nerves, and that can translate into some erectile dysfunction. And so in this regard, prostate cancer treatment can we think it's about 45 to 55% chance of erectile dysfunction after both radiation and prostatectomy or prostate removal. Now, with prostate cancer, there can be some other things that can happen, right? So some patients after prostate removal, in addition to erectile dysfunction, will leak urine when they orgasm. So that's called climacturia. there's a new surgery we have at the time of a penile implant. We'll put a sling in at the same time, and that can help. That's called a mini Jupette sling that was described a few years ago out of a group in France, and I've been doing quite a few of those and having great results. So that's even the things that people don't even mention to their doctors. A lot of times they think, how can this be helped? But that's something we do. Some patients will have an extra fat pad right above the penis that is burying it. So at the time of a penile implant, we can remove that fat pad, get some more length back on the penis, and put a penile implant in either right then or in a delayed fashion, depending on a few factors. So, there's a lot of cool innovations in the field as a men's health expert that we are doing. And, it's just important that patients actually come in to see us so we can, individualize the care and go from there. So let's now kind of go into some of the treatments for erectile dysfunction. So there's oral medications. Everyone's heard of Viagra, Cialis, and things of that nature. There's vacuum erection devices. Then there's this new innovative therapy that we have here at the urology group, the Alma Duo ultrasound wave therapy, which we're very excited about. Then there's injections directly into the penis and penile implants. So this slide, is important because I want to really stress that we have many options and we want to tailor your care to you. So as someone who's trained in this, I'm not only just going to offer you the ultrasound wave therapy that a lot of the men's health clinics will do, because they don't do any of the other things. They're not surgeons. They can't do any of this. So I think in some patients who have really bad erectile dysfunction, if I don't recommend, oral medications, I'm not going to waste your time and, your money and predispose you to side effects because I only offer one thing. So it's very important when you go and seek treatment, if for anything, make sure that practitioner does it all. That's absolutely key, because if you only do one thing, everyone gets that, and that's not individualized care. That's not how medicine is practiced in 2022. So that's important, right? So ED treatments, oral medication. So what essentially Viagra, Cialis, these medications do is they increase blood flow to the penis, and this is important. It does require some sexual stimulation. You can't just pop the pill and wait for things to happen. So it does require some stimulation. It's effective, 50 to 80% of men, and it's not as effective in some men who are diabetic, who've had prostate surgery, so things essentially that can cause some of the nerve damage, let's say. Rarely covered by insurance is definitely a thing we see, and it can be expensive. So that is an issue. Some side effects are headaches, facial flushing, nasal congestion, vision changes, prolonged erection. So the reason the first four of these happen, because while it increases blood flow to the penis, it also can increase blood flow, let's say, to the head, and you get a headache, or you get flushed in the face. So yeah, these things are common, and those are certainly some side effects we see pretty commonly. So Viagra is the one patients have heard of the most. It takes about 30 to 60 minutes to work, lasts about 4 hours, and should be taken on an empty stomach. So that's kind of a bit of a thing that hinders spontaneity. You go out, have dinner and drinks, it may not work as well. So Cialis, this is called the weekend pill, because they say can last up to 36 hours. I think the sweet spot is you want to take it probably 2 to 4 hours before intercourse, and it can be taken with or without food. Some patients, let's say half my patients take Viagra and they like that, half the patients take Cialis. So it just depends, so and we go from there. On Cialis, yes, there is a daily option. That is in patients who have both an enlarged prostate and erectile dysfunction. That can sometimes help and help with peeing and erection. So that's, if you have that issue, we certainly look into that too. And so once again, so our pharmacy at Norwood, run by Melissa Reuter, incredible service. We mail out prescriptions right to your home. We bypass insurance for these medications because they're rarely covered. And for instance, I know the Viagra, sildenafil pills are 60 cents a pill. So they're very affordable generally. And so, no membership costs, and you just buy as many as you need. And I think it's something that is a great service that we're proud of here at the Urology Group. So next is a vacuum erection device. So this is effective in 68 to 80% of men. But the vast majority decide to move on to other treatments. Reason for discontinuation here is that there's lack of spontaneity, there's some discomfort, bruising, and the problem is you have to put this hollow tube like this on the penis, and then there's a constricting band that goes at the base. And many times when the patient pulls off the hollow tube, the erection goes away, and you're not able to penetrate. So it's a bit of, it may not, the patients generally I've seen move on from this. There is some hand or battery powered pumps, and some patients will kind of work with one or the other. Now, I think there is a role for this, right? So I certainly, for instance, I mean, we're probably getting really into the weeds here. And a patient who's referred to me who's had an infection of a penile implant, we're going to redo it. I have them start a vacuum device to promote some blood flow to the penis so that, our revisions will be better. Some patients who are about to undergo prostatectomy, we have a prostatectomy prehabilitation program that we are currently performing at the urology group. And so before the patients start, undergo surgery, they start the vacuum device, and once the catheter is out, they keep it going so that they don't lose as much length after prostate cancer treatment, and that they are increasing blood flow to the area to promote recovery of erection. So I think this has its place for sure, but there are certainly some drawbacks. Next is the Alma Duo ultrasound wave therapy. This is a groundbreaking, innovative treatment that has entered the men's health space in the past few years. So essentially, what it does is this is a focal ultrasound wave therapy that penetrates into the penis and causes micro trauma in the vasculature, and there's some the studies show that it can cause stem cell proliferation, nerve regeneration, and blood vessel formation. So it can many times address the root cause of erectile dysfunction. Now, it's 6 quick 15-minute painless in-office treatments, and some of these benefits we're certainly seeing. There's no expected side effects. All the randomized clinical trials out of Israel and Europe showed no side effects like hematomas, penile pain. There's no downtime, no pain. And there's definitely a potential and the key is it needs to be the right selected patient, right? So if you're a patient who had their prostate out 20 years ago and haven't had erection in 19 years, I'm certainly not going to say, hey, go do this. Now, if you wanted to, it's not going to hurt you, right? There's no side effects, but I'm not going to say, hey, this is it for you, because I have other treatments that I think are better for you. But in someone who has a good response to Viagra or Cialis, but they just need that little more boost, this is a great thing to do. I really believe it. So there's no downtime, no pain, and potential to eliminate or reduce the ED meds. And so actually in Europe, in the EAU guidelines, it's actually first line, right up there with Viagra and Cialis is penile shockwave therapy. So, we're currently not in the United States. So for that reason, it's not currently covered by insurance. So it is cash pay, and so for the 6 sessions, it's $2,000. So that's always a question that patients ask. So this is how it works. It's focused, low intensity shockwave therapy, and then there's per the the randomized trials out of Europe, we have the protocol where the therapist will treat multiple areas on your penis with the Alma Duo probe, and it's been clinically validated to stimulate better blood flow to the penis. And this is the key. It's focal shockwave. It's not radial. So some of the men's health clinics in town will do radial shockwave, and really no randomized trials behind that. So a lot of times they'll quote papers, but if you really get into it, those are focal papers. They're quoting, not radial. So that's something you should ask them. And so this is a nice video of it that we'll show you. Here we go. So this is the ultrasound probe, the Alma Duo probe, and it's placed on multiple areas in the penis, generally 3 on each side for about 6 total, and then we give a few, some shocks to the penis, and that's it. Takes about 15 minutes, and we do 6 treatments over a 3 to 6 week period. And yeah, we go from there. So yeah. So now we'll go to the next slide. Yeah, so people always say, why should we do the urology group and not some of the other ads we see on TV? I think the key is We are urologists. We're the first group of urologists in Cincinnati who are offering the ultrasound wave therapy, and this is what we do every day. That's the key, and we offer many treatments, and if this we think is one that works for you, we'll certainly offer it. But it's up to you, and yeah, I mean that's the main thing, I think. So next, so this is just if you're interested, the QR code right there, and then that will take you to the questionnaire, and it's getting a free online consultation about it with members of our team. So next is injections. So about 60% of men will see success with injection. So essentially, the injection is a really small amount of this medication, Bimix, Trimix, that you inject directly into the penis, and 5 to 20 minutes later, there'll be generally a nice rigid erection sufficient for intercourse. And some patients really like this, especially patients who are diabetic, who are used to using a needle. This is one where they generally thrive with this. So reasons that patients sometimes don't like it is that, yes, there can be pain and bruising at the injection site for sure. There can be development of scar tissue once in a while at the needle site, especially if you do it for a number of years. This is where, there is definitely a chance of a prolonged erection, or what we call a priapism. And if that happens, you have to go to the ER and you have to drain it. So it's rare, but this is the situation where it can happen. And sometimes, just like any medication, you keep bumping it up and you hit the max, and then you have an unsatisfactory erection for penetration, and then that's that. So I think in certain cases this is a great option, but there are certainly some drawbacks, and the big drawback is actually the lack of spontaneity. Reason being that this has to generally be frozen, so a lot of times you have to go down to the freezer, unthaw it, inject it, go back up, and by that time maybe the mood is past. So people definitely complain about that at times too. So this is how it works. You self-inject it directly into the penis. We generally do it the way I recommend at the sides at like 9 or 3, because that way you avoid the urethra and then all the nerves. Needs to be refrigerated. Sometimes, yes, there can be a limited shelf life, so it can expire essentially and not work. So, and only very specialized pharmacies will carry it, but I mean we certainly can steer you in the right direction. But yeah. And then last in the treatment, last but not least, is penile implants. So essentially, let me kind of just show you what this looks like. So this is in patients who have erectile dysfunction that is probably refractory to medications, vacuums, and even injections, or some patients don't want to try injections, which I get. So this is generally the inflatable one you see is a 3-piece device. There's 2 cylinders that go in the erection chambers of the penis. There's a pump that's in the scrotum, and then there's a reservoir of fluid we tuck in the abdomen. So when you want to have sex, you press the pump that's in the scrotum, and it brings the fluid from that reservoir you see into the cylinder, and it inflates it. And so then it's nice and rigid. And then when you're done, at the top, you can see that little valve there, that little nipple thing. And so you press that, and it opens the check valve, and then the fluid drains back into the reservoir, and the penis is flaccid. So and then there is another type of penile implant. So that's an inflatable version. There's a malleable. So essentially there's no pump, there's no reservoir. There's just 2 rods that are placed into the erection chambers of the penis, and they are malleable so that you can, when you want to have sex, you just crank it up, and otherwise you put it down. And this is a good option, the malleable implant. Certainly we do way more inflatable implants, but the malleable is a good option in certain patients who don't have good hand dexterity. Sometimes even in patients who are obese and they can't see their penis, it can help to push the penis out so it's not buried, so they don't have to sit down to pee anymore. So there's definitely some patients we recommend that in, but most times we end up doing a 3-piece inflatable implant. So we're going to just show you a quick video of how this works here. So there's 2 companies who do it. This is the Coloplast Titan device. I actually use Boston Scientific generally for various reasons, but this is a nice video that at least illustrates the concept. So there's these 2 cylinders. There's the reservoir right there, and then cylinders, and then they'll show the pump, I think, in the scrotum. And so you press this a few times, so and what that's doing is that's pulling the fluid. As you can see, the reservoir is deflating, and it's sending the fluid into the cylinders, and then you have an erection. And then the good thing about this is even after a patient orgasms and ejaculates, for instance, you can keep going, as opposed to a normal erection. So that's a cool thing about the implant. And then you press the deflation valve, and then the fluid returns to the reservoir. So, in regard to it's a outpatient procedure. Takes me about hour and 15 minutes to do the case. You go home with a catheter and a drain, generally come back the next day. We pull those out, and then 4 to 6 weeks later, once the bruising and swelling is down and incisions healed, we'll show you how to use it, and you're ready to go. So certainly, the benefit of the penile implant is that it's a one-time thing generally, and you don't have to take medications that may have variable effects, and the spontaneity is great. Once you know how to pump it up, it takes 20 seconds, and you're ready to go. Side effects of the penile implant: so there is a 1 to 2.5% risk of infection, just like in artificial knee, artificial hip, any implant in the body. But we do a lot of things to help mitigate that risk. The irrigation we use, the way we shave, you're getting a urine culture before hip. So we have a lot of things we do, just given our volume of penile implants and experience with it on how to minimize that risk. And then lastly, there is a 6% risk at 7 years that the fluid leaks out of the system, and it's saline in it, so nothing toxic. But then, just like your car tire can pop a leak, this can too. If that happens, we take the old one out and put a new one in. Yeah, that's that. Let me see what's next. Yeah, and that's it. So if you have a few questions here, I'm going to kind of go through now, and if there's any more, please keep them coming, and we'll try to go through them. Okay, so here's the first question. My back surgeon says I will know when I will need lower back surgery when I have difficulty regarding urination, either incontinent or opposite problem needing a catheter. Could this be affecting my ED? I have 4 tilting vertebrae, 3 bulging discs, and some stenosis. I just heard you mention spinal injury, I think L1 through L4. Okay, so yes. So absolutely, the lumbar spine is lumbar and sacral spine are where the nerves that predicate erections do come from many times. So I think, yes, it is absolutely possible. I have seen this in patients who have a spinal stenosis in those area, or bulging discs and things of that nature, that erectile dysfunction can be in part from that. I don't want to fully blame it on that. I mean, I don't know if you have obesity, diabetes, other risk factors, just age in general. But yes, that can absolutely be a symptom. Erectile dysfunction can be as well. Now, I agree with your neurosurgeon that, yes, we do sometimes see incontinence or needing a catheter. Generally, the incontinence we see is from an atonic bladder. It's overflow incontinence. I mean, this is totally out of the scope of this, but yes, so he or she's definitely right about that. But yes, ED can also go hand in hand with spinal injuries and some of these things that you have going on. So if that's the case, I really encourage you to come in and be seen, because I think we do have some options in situations like this. So it's not as if spinal injury means you cannot have sex. I have patients who have spinal cord injuries who have actually had penile implants and are having a great sex life. So it is not doom and gloom by any means. So that's great. Another question kind of goes with this. Is it possible for spinal issues such as severe nerve damage to affect ED? I think we answered that, but the answer is yes, absolutely, 100%. Okay. Next question. I've had my prostate removed 12 years ago, and since I've not been able to get erect and have very little feeling in my penis, the only thing that works is the shot in the penis, but erection is poor. Also, the penis erect length is a quarter of original erection before removal of prostate. Any new suggestions other than penile implant and the sort to solve enjoyment for intercourse? This is a tough situation, I think, because the prostate was removed over a decade ago. So we do know that every year you have erectile dysfunction, okay? you will lose at least half a centimeter of penile length, if not more. So, I certainly hear you on this, that there is shrinkage. And so it's because you're not getting good blood flow to the penis, and it's starting to scar from the inside. Now, the sad thing about this is that it's very hard. You're not gonna be able to get that length back to where you were, but you could certainly prevent it from getting even smaller, right? And so that should be a bit of the name of the game now in this case. Now, I hear you. Is there any other options? I would say the answer to that, I mean, reliable options here besides injections, because if injections are not working, I really think, a penile implant should be considered here, because it will fill that space. It will prevent further scarring. It will prevent further loss of length. So I always tell patients, if you're going to do a penile implant today versus 5 years from now, I would go today, because the thing is, you will almost assuredly have lost at least another inch or two 5 years from now. And God knows how the health is 5 years from now. Maybe you have a heart attack, stroke, God forbid. So it's better to go sooner rather than later. And penile implant procedure is not, I mean, yes, it's a surgery, it's an anesthetic, but it's not open heart surgery. It's your prostatectomy was a bigger deal than this, but it can be transformative. I mean, I really just caution men to go with an open mind. Don't dismiss it. I think as men, we it's an implant. I don't want it, but I mean, women have breast implants. No one thinks twice about it. Why as men do we have shame about this? This should not be that at all. And this is a functional implant. It can help regain intimacy in our relationships and things like that. So I think it's absolutely critical. So in this case, the answer that any other things besides penile implant, I mean, I don't think so. To me, the answer here is a penile implant. I'm now taking shots for my ED. Is there any other thing else I can do? I mean, look, I think if you're on shots for this patient, then you have essentially probably failed Viagra, Cialis, and probably a vacuum device isn't going to work. If you're on shots, I wouldn't recommend probably Alma Duo that much. You could try, but I don't think it's going to be the answer. I think the other option here is a penile implant, and like all the things I just said, it's something worth considering. And the more you wait on something like this, the more loss of length there can be. So the penile implant can help prevent that loss of length and girth. So it's very important. Another page said, I take Eliquis blood thinner. Is there a second part to this? No, okay. I take Eliquis blood thinner, beta blocker, which is sotalol, and none of these treatments are effective. Is there any other alternative that works? And I think that depends on comorbidities, why you're on the Eliquis, but I mean, if you're saying none of these work, I mean, I would want to understand why a penile implant here wouldn't work. I could see certainly medications and maybe injections may still work. You can be on injections in spite of being on Eliquis. I think that's certainly reasonable. But a penile implant doesn't. I have patients on Eliquis who we hold it for a little bit, put it in, and do it. And I can think of one recently where he had an prosthetic aortic valve. We couldn't hold the blood thinner. We still did the surgery. We admitted him and did, it was high risk, but everything went great. So look, all these things are possible. If you go to a high volume surgeon and, these things are possible. So yeah. What is the cost of Alma Duo? So it's $2,000 for the 6 sessions. I think it's $400 if you pay each one individually, but if you pay for all 6 up front, you get the last one free, I believe. So it's $2,000. What conditions reduce success of Alma Duo? That's a great question. So I think patients with severe erectile dysfunction, aka no benefit from Cialis or sildenafil, not even partial erections. I don't think Alma Duo is going to work that well. I think patients who have had prostate cancer surgery and even radiation, I believe, are not going to have the best benefit with Alma Duo. I think patients who have been on injections for a long time probably will not have good benefit. If you've just started, maybe there's some evidence it could work, but so those are definitely some thoughts on that question. Does Alma Duo work if there's a problem with venous retention? Okay, so one of my favorite things to talk about. So I think there's a lot of thing where patients will talk about venous leak, this and that, and there's Doppler ultrasounds that are done. So at Cleveland Clinic, we really, in my training, didn't do Dopplers for erectile dysfunction because I don't think it changed our management, is what I'll tell you. That whether the arterial inflow is the problem, whether the venous outflow is the problem, the nerves the problem, the treatments still stand, so that is just an extra test where you get multiple injections in the penis and we find information that made, at least to me, doesn't a lot of times help my evaluation. Now, certainly in Peyronie's disease, it may be a little different, but erectile dysfunction, I'm not as convinced that it changes much. So I don't think there's really many studies on this, on if does it help with venous leak. I think that's what you mean by venous retention. But I don't know if it matters, I guess, is my argument, like to be looking for venous leak. So, but I certainly do respect there's another school of thought on that, but that's that. Are there any guarantees with Alma Duo treatment? I think one thing I'll tell you, there's no guarantees in medicine at all, and so there's no guarantee that sildenafil is going to work. There's no guarantee that Cialis is going to work. No guarantee injections will work. No guarantee Alma Duo will work. Reason being that these any medication is predicated on your diet, your diabetes, how healthy you are, your stress. The only thing I can say that as close to a guarantee as I can give someone is a penile implant, because it is a device. It's going to work whether you're happy, sad, whether you've eaten 5 donuts. It doesn't matter, right? So so that is because it takes patient factors out of it. So the answer to, are there any guarantees? I mean, that's one thing I learned early in medicine. There's no guarantees in medicine at all. If there was, it would be a lot easier of a job, I guess. So does your urology group do bioidentical hormone therapy for men, either met creams or pellets? So I believe our testosterone replacement is I don't know. I don't think it is bioidentical. But we'll have to check into that. I think that's more of a thing that these men's health clinics will tout as absolutely critical. I don't know if I've seen real data that it's absolutely critical. How much is an implant? So generally, Medicare and commercial carriers will cover the penile implant. Medicaid generally will not. Just given that we are a high volume center, we do have some ways that we are able to help push these through a little more. But generally, like an implant, if it's a cash pay, is about close to $20,000 if there's no insurance, but that's pretty rare. Should I wait until my prostate treatment is finished before seeking information and correction to erectile dysfunction? Oh, that is a great question. So the answer to this has changed. 5 years ago, the answer would be yes. I think the answer to that is now no. I think you should seek treatment now, because essentially what we're finding is that pre-prostatectomy or pre-radiation prehabilitation is critical. So essentially starting patients with a vacuum device, a low-dose PD-5 inhibitor. In cases of prostatectomy or prostate removal, we start Kegels exercises for incontinence. So if you're even somewhere through the treatment, I come see us, come see me, and I'll kind of talk to you about some of the emerging data on this. And I think this is a very interesting part. But I think the answer to that is there's no reason to wait. Starting some blood flow to the penis now can only help things. Next question. I've had good success with Trimix injections. My main issue is some softening during intercourse. Are there other compounds to try, or is Trimix the best? Great question. So Trimix comes in a lot of different doses, right? So it very much depends what dose you're on. We can up titrate the dose. We can have a higher volume, and then Trimix, which is a combination generally of papaverine, phentolamine, and alprostadil. You can add a 4th component to make it quad mix with atropine. And so yes, so you have a bit of a ramp that if you're happy with the injections but you just need a bit of a boost, come see us or come see whoever your urologist is, and they may need to just titrate up the dose or add a 4th component to it. I assume orgasms are possible with implants, assuming there is no other impediment to orgasm. Yes, absolutely. So orgasm, we think generally is a more of a mental thing. Ejaculation and orgasm are different. So patients, like for instance, who have their prostate taken out, they can still orgasm, but they cannot ejaculate because they don't have a prostate. But orgasm, however your orgasm is before penile implant, it will be the same after. However your ejaculation is before, it will be the same after. How your sensation is before, it will be the same after. The only thing the implant will do is give you a nice, firm, rigid erection for intercourse, nothing more, nothing less. So the answer to that is yes. On the implants, why does the length of the penis shorten up? Is there a way to lengthen the penis? So no, I don't think the implant causes a loss of length. No, I think erectile dysfunction causes the loss of length because you're not getting good blood flow to the penis and it scars down. So, people, the $1 million question always say, oh, how long will my penis be after the implant? If you pull your penis on stretch, that's how long the skin is today. That's what limits us, right? So, I'm going to put the biggest implant I can in, I there's no reason not to, but the problem is that patients who haven't had erections for 10, 15 years, they think about their erection when they were 25 years old and it was much bigger. But now that you haven't had an erection in so long, it starts shortening, and they haven't had an erection in so long to even know. And so once in a while that you'll have a patient who's upset. But I'm very, when we have this discussion, I'm frank, like in the sense that the implant is not there to lengthen the penis. The implant is there to give you an erection so that you can have penetrative intercourse, right? You don't have, this is a fully elective surgery. I will tell you when you see me that you don't have to do an implant. You don't have to do injections. You can have a non-penetrating penis. It's there for urination, and that's fine. That is totally fine. Non-penetrating penis is all good. But, if you want to have a penetrating penis for intercourse and intimacy, then, some of these options can absolutely help you. How long do the benefits of Alma Duo last? Yeah, good question. So currently studies are undergoing about is there going to be a touch-up needed, essentially, just like Botox needs a touch-up, when you do it in your face, for instance. And the answer is probably yes. This is not a one and done thing. I don't agree with a lot of the commercials that you'll see in Men's Health, like, oh, you do this and you'll be cured forever. How does that make any sense? No. It essentially, you will, I think it's going to need some type of touch up at some point. We don't know the answer to that because I don't know. Do you develop diabetes, 2 months from now? Did you have a car crash? All these things you can't, you can never give the longevity of how long a medicine will work or one of these things. Now, I can tell you the longevity of a penile implant because, like I discussed last time, it does not matter what you do to your body, whether you smoke a ton of cigarettes, you eat donuts, penile implant is going to work. So 94% of penile implants work 7 years after implantation. Anything else, I don't have data for like how long do the benefits of Viagra last? I don't know the answer to that, So it kind of goes in that same grab box. Next is, I'm assuming the inflatable penile implant options are not covered by Medicare insurance. We already discussed that. I've heard that some people have success using half Cialis pill on a daily basis. Yeah, great question. I agree with that. So in patients who have both erectile dysfunction and enlarged prostate, and with the enlarged prostate, they're having weak stream, urgency, frequency, things of that nature, the daily Cialis can help to open the chokehold of the prostate and the urethra so they pee a little better, and it can help promote some blood flow to the penis. So yes, a dose of either 2.5 milligrams or 5 milligrams of Cialis daily can definitely help with that, and there's good data behind that. Next question. I had a TURP procedure several years ago and have all the bad side effects: ED, incontinence, and retrograde ejaculation. Will the Alma Duo work for me? So the retrograde ejaculation and the incontinence will not be affected by any of these procedures, pills, penile implant, Alma Duo, those are totally different situations, right? So in this situation, when I'm hearing that you have incontinence in addition, ED, seems like, it's maybe a little far gone that Alma Duo may not be the answer here. So, I wouldn't push that in this case. In my opinion, we want to give Alma Duo to patients who have mild to moderate erectile dysfunction. And so this sounds like a little more on the moderate to severe side. So potentially not. I think, and this is, whoever sent this in should come see us, because incontinence after erectile dysfunction, we have other options, for incontinence, such as an artificial urinary sphincter to help make it so you don't leak when you cough, sneeze, lift heavy things in men. I'm talking about, not in, this is opposed to as in women. So I think that in this situation, this is a more complex situation, and potentially, you should come see me to kind of go from there. Next patient, I had one testicle removed. Would this affect any of the options, especially pills, Alma Duo, or implants? Okay, one testicle removed. No, I don't think it should affect any of those options, honestly speaking. I mean, I think we would check your testosterone level for sure. I would want to see what that is, but I don't think I'm trying to think about, as long as no, shouldn't matter. Penile, I remember, I can think of just 2 recently penile implants I've put in patients who had one testicle. It actually makes the surgery easier. So yeah, it's no big deal. Will Medicare pay for implants, and what do? Okay, yes. So answer is Medicare does pay generally for penile implant, which is great. Yeah. Any method to get more girth after an implant? Yeah. So this is something that's being experimented with, let's say, and studied. So a lot of people want increased girth. So there are some solutions for this. They're still very, very experimental. So there's fillers that people put in the penis. So people have done silicone, fat fillers. I would run away from all those ones, because the skin can necrose, aka the skin can die, and you need skin grafting. Now, the one that's interesting, that it may in the future be something that we do, is hyaluronic acid fillers to the penis. And so, that's what's generally given in lip fillers. So essentially, you got to do it every few months because it degrades. And there is a kind of, if you don't like it, you can give the antidote hyaluronics to it, and it will break it down. But that's something. Now, there is an implant actually new on the market that's done by very few practitioners, called the Pneuma. And that's an implant that kind of sits like a shield on the penis and can help have some girth enhancement. Look, I mean, I'm always evaluating these things, and I will jump in when I see the data. That's what I'm going to tell you. And I just don't think that these are ready for prime time in my eyes right now. But there are certainly a few practitioners who are offering, for instance, the Penile Implant, and that's something that some patients may want to do. But I certainly know all these are cash pay and pretty expensive. Next patient, I don't have problems getting an erection, but I cannot keep an erection longer than a minute, sometimes even less. I am on blood thinners as well. Would any of the solutions you mentioned, other than a penile implant, which I think is cost prohibitive, work for me as well? Yeah, I think in this case, I mean, it depends if this patient has tried Viagra and Cialis, and at what dose, okay? And then if that isn't doing the trick, I mean, vacuum you could try with a ring on it and see, because that is, that essentially, if you're getting the erection, maybe some blood is leaving too fast, so that is an option. But I think the injections may be a good option here, because generally injections can help maintain an erection. So yeah, if you don't want a penile implant, maybe an injection here could help. Is it possible to get results with chronic nerve damage from Alma Duo treatment? I don't have any data on that, to be honest with you. If there's chronic nerve damage, I haven't seen any studies on that, so hard to say. I mean, one thing I'll say, I mean, what we know from about ultrasound wave therapy is that all the randomized trials show no negative side effects. So that's the good thing. There's no hematomas, penile pain. So you can certainly try it, but I haven't seen any data on that. There are devices on the market, Phoenix, that can be purchased, and Alma Duo type treatments can be self-administered with these devices. How do these treatments compare as far as effectiveness? Are there any cautions that should be considered with self-administered solution? Yeah, so the generally speaking, I think I don't know much about the Phoenix, but I believe it's a radial shockwave, and so that is kind of the big thing, focal versus radial, and so I mean. But I don't think there's any problem, like self-administered. I don't think you're going to hurt yourself doing that. But is it going to be of benefit? I'm not 100% sure on the Phoenix. So yeah. What is the approximate cost of the penile implant? So we talked about that. Is it covered by Social Security? I think, yeah, Medicare generally does cover it. I have perfect Blood labs, I am a bit obese, but a lot of muscle mass. My S1 vertebrae and discs above and below are pushing against my spinal cord. I have chronic nerve damage on the left side, down the left leg. Should I attempt the Alma Duo? Once again, this is that chronic nerve damage issue. I mean, I haven't seen any data behind it because it's, you know, a newer innovative therapy. You wouldn't hurt anything trying it, I'll tell you that. But you know, I think this is one where I would say you should call us and just have the free online consultation so we can really do a deep dive and kind of go into it and see if, you know, if it's something you wanted to do. Is the less expensive, I assume, generic pills offered through the urology group generic Viagra, Cialis, or is there a choice? We have both. So Viagra generic is sildenafil, Cialis is tadalafil, so both are offered. Can you combine Trimix and Viagra? So the answer to that is you should not. You know, you should do one or the other generally. Do any of these treatments have a positive effect on premature ejaculation? Okay, yeah, another favorite topic of mine. So premature ejaculation is totally different, I think. So in the sense that I don't think any of these things will affect premature ejaculation. Now you have to kind of think though, sometimes with premature ejaculation, you know, the treatments are a little different. So first line for premature ejaculation is a numbing cream to the head of the penis to desensitize a little bit. I think the one that I generally recommend is called Promescent. It can just be bought online. It's about $20, and that can help. Second line is cognitive behavioral therapy. So we have a very good sex therapist that we send patients to, and she helps, you know, some techniques to essentially help with premature ejaculation. And lastly is they found in patients who were taking antidepressants such as Paxil, fluoxetine, things of that nature, SSRIs, that one of the side effects was that it delayed ejaculation a little bit. So you know, that is another thing we can do. But generally, no, these treatments are for erectile dysfunction. If I find myself in a relaxed position in my recliner and I'm very tired, I tend to get erections out of nowhere. Why is this? Yeah, so generally, sometimes these like erections like this or nocturnal, people wake up with erections. These are physiologic erections. These are not erections that are stimulated generally by, you know, sexual desire and stimulation. And so a lot of times we think like if you have a full bladder, for instance, it's a reflex that you'll get an erection. And so that doesn't necessarily mean you don't have erectile dysfunction. It's just that's a different type of erection. And its main thing is it's not reliable, right? Like it just happened out of the blue. You can't, you know, when it's time to go, you can't make it happen. So you know, but yes, that's kind of normal actually. What's the implant difference between companies, pumps, reservoirs? Yeah, it's a good question. I mean, so essentially, there's two main companies in the United States that make inflatable penile implants. There's the Boston Scientific and Coloplast. So I think it all comes down to, I think they're both good products. I trained at the Cleveland Clinic, and there we used always the Boston Scientific. And the reason, I think in my hands, I do, you know, that's what I'm most comfortable with. I think it makes the most sense, and all my mentors who you know are some of the world experts in this, they stand behind it too. The things I like about the Boston Scientific for me are that there's an inhibizone antibiotic coating on it. I think that's absolutely critical. That lasts about 60 days and can, you know, we think help with infections. But to me, the name of the game is infection prevention. And you ask any implant surgeon, I'm talking about orthopedic guys who do knees, hips. I mean, that's the thing that we want to avoid the most, was that's a bad outcome. So the Boston Scientific device has that coating. I like the pump of the Boston Scientific device. I think it's very user friendly. I think patients pick it up pretty easily, and I like that. I like the reservoir, which the patient doesn't interface with, but surgically, I think it fits nicely in where I need to put it. It's not palpable to the patient. And I also like just the feel of it, the implant, especially even when it's deflated. I don't feel it's as clunky sometimes as the Coloplast implant. Now, the people who do Coloplast, they talk about, they think the girth is something they like about that, but I think the Boston Scientific is fine. And then they like to use it a lot of times in Peyronie's cases, but I've done many Peyronie's cases with Boston Scientific, and as have a lot of my mentors, and there've been no issues at all. So, I think there are certainly, you want to, the main thing is you want to go to a surgeon, I think, who's high volume, who does a lot of these. And, so we did close to 100 last year, and I think we're on course to hopefully exceed that this year. So, we certainly do a lot of these prosthetic surgeries here. About how many pumps to get a full erection. Yeah. So another good question. The answer to that is, you can't say, because it depends, like, is your pump this or is it this? So when I pump it, for you, I will be like really pushing it. So I probably will need less pumps, but I'm also not feeling the tactile feedback that you may on your scrotum. So you probably may not push it as hard. So the answer is there's no, you pump it as many times as you can to get it as rigid as possible. But, you can never pop the implant. The amount of fluid that we put in is tailored for each implant. So that's a common question, but, it's just, it ends up being, a few, but there's no set number. In checking other causes of ED, how would you determine if one cause was psych meds? Just knowing how probable a med's ED side effect isn't enough. Would you, with your doctor, cut back or stop one to see if it helps? It's a good question. The answer to that's no. I certainly don't have the expertise to cut back anyone's psychiatric medications. I'm not the psychiatrist, and I certainly would not want to. But, I will tell patients, hey, look, like this Abilify, I know may cause it. Please talk to your psychiatrist if they can do that. So that's something we can do, but I certainly, I stay in my wheelhouse because I want to be able to do things that I know I can manage. That's the key. And so, but, we do definitely look at your medications and at least give you some recommendations. So, but once you speak to the practitioner who's prescribing it, that's, that we close that, we want to close that loop. So, yeah. I think that's it. I think we got through all the questions. So that's great. So I just want to thank everyone for tuning in. I think, please, give us a call and come see us, and we would be happy to kind of see you and kind of go from there. So thank you so much, and I want everyone to have a good evening. Thanks so much.